Hi, everyone. My name is Ashley Tucker, and I'd like to welcome you on behalf of the Scleral Education Society to our June webinar. Tonight, I'm really excited to have two presenters, and that's Rebecca Petris and Dr. Christine Sindt. Rebecca Petris is a patient advocate who has worked with ocular surface disease patients and scleral lens users for more than 20 years. She's a co-founder and executive director of the Dry Eye Foundation, a 501c3 nonprofit patient education and advocacy organization based in Poulsbo, Washington. Dr. Christine Sindt is a graduate of the Ohio State University College of Optometry. She completed a disease-based residency at the Cleveland Veterans Administration Medical Center. Dr. Sindt joined the faculty at the University of Iowa Department of Ophthalmology and Visual Sciences, where she is currently the director of the contact lens service and professor of clinical ophthalmology. She also serves as a consultant optometrist for the Iowa City Department of Veterans Affairs Medical Center. She holds 7 U.S. patents and has over 150 publications. She regularly travels to conferences both nationally and internationally. She has had numerous funded research grants. Her current research projects include elevation-specific scleral lens design, higher order aberration control on contact lenses, ocular health associated with scleral lenses, and smart contact lenses. She is also the inventor and owner of iPrint Prosthetics. Please welcome Dr. Christine Sindt and Rebecca Petris.
Thank you so much for having us.
Thank you.
Thank you so much. It's a real honor and pleasure to be here tonight. I am so grateful to the Scleral Lens Society for hosting this event and to Dr. Sindt for everything that she brings to the table on this topic, which I'm just really excited about. Bear with me 1 second while I get our slides going here. All right, so tonight's subject is integrating the patient's perspective in scleral lens management. And I want to do just a quick rundown of the ground we're going to cover tonight. First, we're going to be talking about where we patients are coming from broadly when we start or even approach the scleral lens process. And that's all about creating some context around a discussion about the kind of partnership we need with our providers and the kinds of conversations and resources that help set us up for that really strong partnership that we need to go through the scleral lens process. Then we're going to walk through each stage of that process, from fitting and training to adapting and living with scleral lenses, all from the patient's perspective in terms of some common challenges and how knowing those challenges can empower you to partner effectively with patients. So I'm kind of a straight to the bottom line type of person, and right out of the gate, I just want to share my 2 keywords, and they are anxiety and complexity. For us, an awful lot of us scleral lens patients, and by the way, I've worn scleral lenses since 2006, scleral lenses are not just a specialty contact. In terms of life impact, there's something like a cross between a medical treatment and a prosthetic. Whether we're vision patients with irregular corneas or ocular surface disease patients or neuropathic pain patients even, or for somebody like me, those that have all those things rolled into one. And because of the history behind our need for sclerals, we scleral lens patients often walk in the door carrying this enormous burden of anxiety. And it comes in all different flavors. And Dr. Sindt, jump in anywhere you want.
Yeah. Well, let's talk about the word anxiety for a second. Okay. I think that, people come in with their anxiety, but when somebody is anxious, it tends to make the room anxious. It makes everybody anxious, so they walk into a practice and people feel it on you. And from a doctor's perspective, it's about learning to navigate that anxiety, but keeping everybody else in the practice less anxious. Your technicians and your front desk staff, and everybody has to learn how to navigate being super uncomfortable, right? And getting everybody to the point where they are super comfortable. So from a doctor's perspective, for me, it's not just about the patient. It's about all these other people that are going to be involved in this patient's care. And I have to kind of glue it all together and start to navigate that. So anxiety is it's infectious, really. And we really have to think of it as something that can grow legs all on its own.
Wow. Right. When I think of flavors of anxiety that we carry in, I think about the vision related anxiety. I mean, we are wired to fear vision loss, right? So that comes in all different ways, and we don't necessarily wear it on our sleeve, and we're not necessarily 100% conscious of it ourselves, but it does kind of feed the process. Some of us have pain driven anxiety, and that comes into play, especially if we've got a history, like a lot of us ocular surface disease patients have, where our symptoms are way out of whack with the clinical signs. Some of us have got risk-related anxieties. A lot of us have treatment-related anxieties, like we've been through so many treatments that we are virtually conditioned to expect all treatments to fail. And we may walk in the door afraid to get our hopes up. Some of us have big financial anxieties. Is my insurance going to cover enough of this? Oh my God, I had to borrow money to do this. What if I end up having to quit my job? Then I'll lose my insurance. All that to say, we've just got so much riding on this. We walk in the door with seeing this as a very high stakes exercise. So
yeah, so when I see that, when somebody comes in, I'm well aware of all of the different type of anxiety that people bring with them. And when somebody's sitting in my chair, it's almost like I have to take that little suitcase of anxiety and open it up and just start unpacking all those little pieces, just kind of hanging them up and airing them out and saying, how are we going to deal with this? How are we going to deal with this? Because from my perspective, when I'm starting the process, if I don't understand all of those things, if I don't understand them, I can't just make an assumption, right? If I don't understand it or what is driving that patient the most, it's all going to fail. Everything, my time isn't going to be worth it, even if I'm looking at it from my perspective, because I will spend all this time and it will fail because I have not addressed what is the elephant in the room, so to speak. And here's maybe one of the most difficult parts. Oftentimes, people don't know. They don't know they're carrying that anxiety, or they don't know exactly what that anxiety is. And so from my experience, right, what has led me to the place that I'm at, I have to proactively ask things. I have to ask them. We have to have the financial conversation, not just how much is this going to cost, but how is this going to happen for you, and how can we make it happen, and set up a plan for success. And every one of those anxiety things that you brought up, we have to then create the plan for success. How are we going to be successful with this? The two most common anxieties that I see walking into my practice that I really have to address is fear of the future. How am I going to support my family? Is my child going to be able to drive a car? What does the future hold, right? Almost, and it's a little difficult because it's almost like borrowing trouble, right? People become anxious over things that literally have not even happened yet, and I'm like, whoa, I have to guide people back to let the here and now, and then we're going to talk about the future. So it's what's going to happen in my future. And the other thing that I really have to address is the PTSD component to it, right? Post-traumatic stress disorder is a huge part of what people deal with. It's almost like people are waiting for the other shoe to drop, almost like they're just waiting for the thing to happen because they've carried this burden for so very long. Now, different diseases carry different types of anxiety as well. So somebody with keratoconus has a different perspective, say, than somebody that has Stevens-Johnson syndrome. When somebody has Stevens-Johnson syndrome, for example, they almost died. And we have to navigate that fear of death with that patient as well. Or graft versus host, that fear of death is always there, and I have to remain present with it, and I have to help them work through that while keeping them comfortable, while making them see. It's not about the plastic. This is the crux of the whole exam, is working through them on that level. Keratoconus is different. People with keratoconus are really focused on their activities of daily living. Can I drive? Can I go to work? Can I perform? Can I support my family? Can I do this comfortable? Does it disrupt my day? And those are the type of things that we have to focus and address. Now, everybody's different. Everybody's going to carry their own thing, but each disease, I think of each disease as sort of a separate thing that I have to unpack, little suitcase. And I have to start unpacking for the patient before I even touch them. Sometimes the whole first exam is just unpacking their anxiety.
I'm thinking also of just like when you talk about PTSD, thinking of some of the medical trauma type situations too. And when it's iatrogenic, it just brings whole new kind of dynamics there. So we have all that. We walk in the door. We're starting to try and build that relationship. And we're approaching the scleral lens process, and then we're confronted with all this complexity. And this may be before we walk in the door, right? We're reading up about scleral lenses online, and it's like we're staring into an abyss of the unknowns. We have 10,000 questions before it all starts. Like I said, questions, how will it play out into the future? But what will the process itself be like? And then, of course, we go on Facebook, and we come away maybe both more informed and more anxious.
Mm-hmm.
Then what?
Well, let's start at the beginning of the process again, right? Because we have not got off the starting block we have not fully addressed anxiety here, right? Because I think that's still where it all stands. And so when I start a process with a patient, I walk into the exam room and I look at the patient. I look at how they're sitting in my chair, what their posture is in the chair. Do they have somebody with them? Who is that person? What is that person's relationship to them? I love it when people bring their plus, I call them their plus ones. But when somebody brings their plus one, I have to develop a relationship with that plus one as well, right? And that plus one has also done a Google search on their important person's disease as well. So they come with a lot of questions. And when I walk into that room, many times I find that the patient just wants to word vomit on me, and if they could, they'd just be like, here's everything, and they want to get it all out at the same time. And that's not good for them. And it's not good for me either, because if I just answer questions all over the place, right, that if I don't do it in a logical, linear way, we will forget things. I will forget things that I know they need to know. We won't be able to answer it in the pattern that I'm going to teach them to recognize how to move forward with their disease. So the first thing I do is when I look at the patient, I say, who are you and what are you bringing here today? Now, there's two types of patients. There's the patients that sit there and their posture is very open. They're ready to absorb information. And then there's the patients that sit there and their arms are crossed, and you can almost feel like, how are you going to be different? Why are you going to be different? And I'm kind of mad and I'm kind of ticked off at the whole situation that is going on. And I understand that. I get it. I totally get it. And I have to shift how I interact with the patient. But overall, no matter how they're sitting in my chair, they have to tell me their story. I have to know what are their expectations for moving forward. And really, that's the thing. We have to have expectations set appropriately. So I kind of hear their story a little bit, and I listen to their partner, and then I'll say to them, I don't know what you know, and I don't know what you don't know. So let me start at the beginning and just ask you some questions as we move forward. And through this process, after I've heard them, then they're open to hearing me. And then we move forward to find out, I tell them, just take keratoconus, for example. Do you understand what your disease is? And do you understand the steps that got you here today? Because again, a lot of that anxiety that people carry with them, it's because they don't fully understand what their disease is. So now they've Googled it and they have found a lot of words that don't make sense to them. And it's scary. And they've Googled corneal transplant and they've Googled all sorts of things. And that's scary. And so that part of that, getting to know the patient in this way, I then understand what they understand. I understand at what level they need to hear the information, right? Do they need to hear the information on, what do they say? All media is written at a third grade level, right? Do they need to hear the media at a third grade level? Or, maybe they need to hear it at grad school level, right? And I need to make them an associate by the time we get done with it. People have different levels that they need it at, and I have to change that as I move forward for people. But ultimately, it's to get that care path. Yeah.
So with all of these burdens that we walk in the door with, I mean, I often feel in hearing patients' stories like there's just no doctor can be expected to solve all of these problems associated with our eyes that we bring to the table, right? How do you dial that back and set boundaries around that to say, okay, we got a really large burden here. Here's my piece or pieces that I can help with. How do you introduce that idea to people to maybe direct them to some other resources?
Well, it goes back to understanding what their problems are. And it goes back to one, understanding what the problems are, and two, understanding not just my own personal boundaries, but my own personal abilities. And I joke that it takes a village to raise an eye. But it's true, and I have very close working relationships with my cornea specialists, but also my orthoptists and, and people in the community, doctors outside that are specialists in dry eye or things. And I will then say to the patient, it sounds like you have, X, Y, and Z going on. And my area, my specialty is this area, but I know very good people in these other areas. And together as a team, we will get you seeing and we'll communicate. That's one of the hardest parts of eye care is when you're a specialist in one area is, you think the eyeball is like the size of a grape, right? But yet there are so many specialists. And when people feel like they're not all talking to each other, it gets very complicated and you feel abandoned, right? And so you really need to have somebody who's going to say, I'm going to steer the ship and I'm going to talk to these other people. And so for me personally, and this is just a me thing, I like to be the party planner. I want to be the party planner for your eye. I want to know what's going on. I want to put it all together. When you have questions, I want you to call me. If you don't know the answer, I'm going to source it for you. Because it turns out that me personally, I'm kind of a control freak in a very loving and gentle way. But you need to find that person, right? Somebody has to be the party planner for your eyes.
I love that. Can we talk a little bit about the fitting process, just kind of launching into where we get going on things? I feel like a lot of what patients struggle with in that process is, I just want to know what normal is, right? It's like, how many fitting sessions is it normal to have? I'm on my third lens. Oh my God, should I be sweating or not? How long should the whole process take? How comfortable should a lens be? Is it normal to feel this? Is it normal for my lens to do that? Is it normal for my doctor to say this? We have no framework of understanding for it. So we sweat about everything in it, right? How do you set some expectations or frame up what will this look like? I mean, knowing that there are some unknowns, we don't know exactly where we're going to come out the other end. How do you set that up?
Yeah, all of that has to happen before I even touch the patient. Before I do anything, I have to have that conversation. Now, I know what my normal is, right? I know what my normal is. I know for a certain disease, I can look at a certain topography and I can say, this is complex, this is not complex. So I know what my normal is, but normal is just define normal. That's a really hard thing, right? Because one person's normal is not normal for somebody else. But at that initial what to expect conversation, once I've heard the patient, once we've established their goals, and expectations, okay, and I have to circle around, and sometimes that takes a while because you have to say, not just what are your expectations, but sometimes you have to say, that's not an expectation that's going to ever happen, right? It's so much easier to say that at the beginning before anybody has spent any money than it is at the end and say, well, you were never going to see great. You're a 68 diopter cone, right? All words that strung together that one, the patient doesn't understand, and two, sounds terrible, right? You have to have these conversations right up at the beginning. So you have to set those expectations. And I think that's really the key is I will tell patients with here's what's going to happen. I am going to do blah, blah, blah today. When you come, then I'm going to order you a lens. When you come back, this is what's happening at this visit. Then I'm going to send you away for a month or whatever my schedule allows. And then I'm going to see you back one more time. I'm expecting this to be done in 3 visits, or I'm expecting this to be done in 4 visits. If something comes up, people surprise me all the time. It turns out people are squishy. People have other things that show up. We will then deal with that when that happens. But this is what I'm expecting right now. But that has to happen before I even touch the patient.
That's what we need so much. I mean, we need to know at least a rough framework of kind of a calendar. What are the major events? Roughly when will they happen? What are 1 or 2 of the variables that may come up? I mean, knowing any of it helps us control the extent to which we might feel like we need to know all of it, right? Mm-hmm. I wonder if you could speak to the vision outcome expectation piece from the standpoint of like presbyopia. This is something that comes up a lot in our community is, wait a minute, but I don't want to put on readers, where people don't understand that they may get both types of vision.
So keep in mind, I've been in practice almost 30 years now. So do quick math in your head. You'll know how old I am. And I will tell you that conversation is easier for me now than it was when I was younger. Because now I can just look at somebody and go, yeah, I here's what I can do. I cannot solve the old part. Right? And I mean, I can't solve the old part. I would with myself too, right? You're old, I'm old, we're all old. We have to deal with that. That has nothing to do with your disease, right? And I'll tell people we'll get you seeing. If you want to talk about doing a bifocal, you can bring that up to me at a later date. Because I see this as an ongoing relationship. My patients, it's not a I'm get them fit and we're done relationship. I have 10, 20, 30-year relationships with these people. Bifocals are really tough, especially with disease populations, because you're adding in aberrations to a system that is already messed up. And so it's a very difficult thing to do.
I think that us patients, we just don't know what we don't know, right? So if I've been a glasses wearer all my life and I take off my glasses and can read now that I'm whatever age, then the idea that after I get these scleral lenses, I might not be able to do that just can come completely out of the blue. So we don't know what we don't know. We don't know which questions to ask. We need our providers to anticipate some of that and get into that. I mean, as a scleral lens user, I started wearing scleral lenses in my late 30s, early 40s. And I mean, now I wear bifocals that are like plano on top and readers underneath because I don't like taking readers on and off. So I just keep these on all the time. But those are sort of things that I had to work out for myself over time.
That's a really hard thing, Rebecca. Yeah, I totally hear what you're saying with that. And it's something that I actively have to work on every single day in my practice too, because people, even if I explain it to them without perspective, it's hard to understand. And so, I can say to somebody, but when I put your contacts on, you're not going to be able to see up close. And they will say, but I see great up close. And I'll say, I know, but when I put your contacts on, you're not going to be able to see up close. And they'll say to me, but I see great up close. And I'll say, well, when I put your contacts on, if you can see up close, you can't see far away, but I want to see far away. We have these cyclical conversations. So it's, as an eye doctor, I have to be aware that one, they just don't have perspective, right? Nobody's being stupid or difficult or anything like that. They just don't have perspective on it. And two, sometimes we have to look at some of these things with humor. And I will say to my patients, I totally think we're going back and forth on this right now. So I tell you what, we're going to get the lenses. I'm going to show you how you see far away. But remember, we're going to have to talk about this up close thing when you come back. Okay. And then the patients, they're like, okay. But when they come back, they understand. Once they live it, they get it. Right. But then they know that I also get it. And even if it's not what they want, as long as we both understand that the other person understands, we're good.
Okay. I'm looking at the Q&A. I see a couple of questions from patients. Going to circle back to those in a little bit. I do just want to mention posting questions for patients that are in the group. Posting questions is fine, but we can't answer. No medical questions are going to be answered here. Can't answer medical questions that are individual to you. Can we jump into the insertion and removal training topic? Then we'll circle back and tackle a couple questions.
Yeah.
Okay. So there are people out there, right, that learn really quickly on a standard DMV plunger with a standard technique. And then there's everybody else, right? The ones who take longer, who need different tools, who need different techniques. And when it starts getting rough, some really uncomfortable things can be going through their heads. And that fear can start to spiral about whether this thing is going to work, whether it's all going to break down on the question of, can I get the blankety blank things in my eyes? Mm-hmm. So what does a provider need to know, need to have, need to do to set patients up for confident training?
Right. Well, it goes back to that anxiety that we talked about before. So sometimes we have to know what their anxiety is. And then we have to just hit that head on. Let me give you an example. I had a patient recently who, a younger patient who was in the room with parents, and she was getting a lot of positive encouragement from everybody around. My team was like, you can do this. And the parents were like, you can do this. And everybody was giving her all the reasons why putting that scleral on was going to be super successful and life-changing for her, and she needed to do it for the future. And don't get me wrong, she did need to do this for her future. She had a disease where we had to get that lens on. It wasn't an option. Blind was not an option we were going to all go for, right? But I could feel it coming off of her, that there was this anxiety, like you were mentioning before. And so I just sidled up next to her. I quieted everybody else in the room. And I just said to her, you know what? Right in this moment, you don't have to put that lens on, but we do need to talk. So now's your time to talk to me. Tell me what you're thinking, and we were able to have this very lovely conversation about her fear that the contact lens was going to scrape her eye. So I said, oh my gosh, that is such a real fear. I understand that. That is, wow, that you've been thinking about this a long time. I said, let's come up with ways to make sure that does not happen. Right. And so then the rest of teaching her how to put that lens on centered around techniques for her not to have that lens scrape her eye. And, and then we were able to be successful. Right? So understanding that anxiety is a huge component to it. When people can't get it in, we have to back it off and say, let's talk about this a little bit more.
That's awesome. So de-escalating, unpacking the stress piece of that, and uncovering information that you wouldn't have gotten any other way. What about the purely technical side of it? Though, people with tremors and maybe a really strong blink reflex. Could you speak a little to just maybe the variety of stuff and approaches, the creativity aspect that may need to come into play too?
So first of all, it doesn't all have to happen in one setting, right? And if it's escalating in the room, it's totally okay to take a break and walk away. So don't let things escalate. The next thing is, how do you get it on? Well, oh my gosh, there's like a million different ways to get a contact lens on an eye. Whether it's you doing it all by yourself or whether you have a helper with you. There's so many different ways, whether you're using a tool or using your finger. And as doctors, we have to have all of those different things in our practice. Right. So it's important to know what kind of finger dexterity does somebody have, right? Because people that have really good finger dexterity or smaller fingers, they may do better just by holding the lens with their hand. They may feel like they have more control holding it in their hand. Some people feel more control on a plunger, but does it need to be a large plunger or a small plunger? Does it need to be a ring plunger? Do they need to have a handle on the plunger, or can they hold the plunger, right? This is a different grip than this. It's like a chunky spoon versus a little spoon, a big crayon versus a small crayon. Okay? These are all things that we can take from all these other industries that have all the dexterity stuff worked out, right? There's so many different options. Do you put the head to the lens, or do you bring the lens to the head? Are their eyes forward or are their eyes deep set? Sometimes I have patients where I swear their eyeballs start somewhere around their earlobe. They're so deep set into their head. Well, that's a different technique. Sometimes people that have very deep set eyes can't get their lenses in. So we stick BandAids to their upper and lower lids and pull their eyes open and put the contact lens, so they're not actually have their hands around their eyes. There's a million different ways to get a contact lens in somebody's eyes. And I will tell you, about 99% of the time, it's about the technique that makes sense to them at first. But like I said, about 99% of the time, they're going to go back to just a very simple technique of putting the contact. Like everybody works it out in the end, and almost everybody gets to a very simple technique to getting it in, even if they had to do a very complex technique at first.
Okay, thank you. I'm going to jump into the Q&A here now. Slightly unanticipated problem, difficulty reading. But let's see. So we have a ClearCare question, and we're just about to get into our section on supplies and things. So this will fit in here. If I don't wear my lenses for a while and they've been in the ClearCare little basket with ClearCare, as long as I wash and disinfect them well, is there a problem wearing them again? So what happens when you've been storing your lenses in solution for a while, specifically?
If you're storing your lenses in solution for a while, you need to read the instructions on whatever solution that you have stored it in. And there will be a recommendation for the length of storage time for the solution that you're using. How often you need to replace the solution, et cetera. But if you have it in for a longer period of time than that, then you do need to clean the contact lens and then run it through a cleaning cycle just per the instructions on the box as well. So if it requires a 6-hour soak, then you need to soak it for 6 hours. You can't just take it out of the container. You do need to run it through a cleaning section if you have not worn it in a significant amount of time. Regardless, it's not just ClearCare peroxide systems or multi-purpose systems or anything. You read the instructions, that 2-point font on the inside of the box.
Thank you. I'm going to throw in a little tip here that I think is a helpful one for providers to share with patients too. And that is those instruction sheets in those solutions are small. So my favorite thing is either I look it up online and kind of blow it up on a big screen on the PDF from the manufacturer, or I take a picture of it with my phone and blow it up. But some of them are hard. I mean, I've had to look up a lot of those, and it's like those big fold out sheets in the kind of don't read me font size, and you're trying to find the section where it says it. It'd be kind of cool to have an online thing somewhere that just has that information handy. Anyway, right. Thank you.
With the you know, those sheets are regulated by the FDA, and it has to have certain language and certain requirements, and there's certain things in there. They're not necessarily the most patient friendly way to do that. You know, we have an after visit summary that we put out, and we include in the after visit summary whatever they ended up going home with, whatever tools, whatever solutions they ended up going home with. It's tailored to that, pulling out sort of the germane parts of the process that need to happen. You're right. I wasn't joking when I said it's written in 2-point font. It is the tiniest stuff ever. Yeah.
So I'd love to hear more about that take-home sheet that's personalized. So talking about supplies, and I mean, our salines, our multipurpose solutions, the clear care, and even plungers and things like that. Classic challenges we patients face: confusion up the wazoo. We will sit there in the chair and we will be happy and we will smile and we will nod and we'll say, yep, got it. Yep, got it. Yep, got it. And we will go home and we will say, oh my God, I can't remember anything.
Mm-hmm. I actually addressed that at the very first time I talk to a patient. One of the very first things I say to them is, I am going to give you a lot of information, and most of it you won't be able to remember, and that's okay. If you have questions, you call my office, right? But I think they did a study that said, you know, when you're in a doctor's office and you have to put on the little gown, you don't remember a single thing that happens after that. Well, I don't make my patients wear the gown, but you know, you give them a lot of information, and people don't remember things, you know, it's hard.
We don't. I mean, I've talked to people sometimes where they will swear up and down that the doctor said use this solution for this. And no, we really don't want to fill our lenses with the MPS, right? So we know it's backwards, but it's so easy to get confused. Because again, to me, it all goes back to the anxiety plus complexity, right? We're walking in the door with the stress, and it's hard to shed all of that. And when we meet too much information at a time, we just can't retain it all. So having things in written form.
Yeah, it's okay to be confused. Like, that is fundamentally okay. Like, I will never judge anybody if they're confused, right? I just want you to call me. I want you to call my office. I've got this amazing staff. Let us walk you through it.
So what do you do to guard against the patient who isn't confused, but is simply wrong? They got it wrong. They're doing it wrong. They're remembering it wrong. How do you make sure, you know, when they're coming back and all that they're sticking with the protocol that you gave them?
Well, we ask it every time they come in. That's one of the things that we ask. How are you cleaning your lenses? What are you cleaning your lenses with? If we get any whiff that it's kind of going wonky, or I see something that's going a little wonky on their lenses, I will circle back around and I will talk to them about it again. Lens cleaning in particular, lens care in particular, is a constant, battle's not the right word, re-education. It's easier not to, but success depends on it. And so it's just something we simply need to do.
So reviewing what they're doing and lots of repetition. Some of the areas where I see people getting confused on, particularly, sometimes it's just the order that things are done in with the different solutions. Storing lenses short or long term, what to do with them when I take them out for a nap for a couple hours in the afternoon, what to do if I'm not going to wear them for a couple weeks. Then I don't know how to use this solution in a case where it's being used off-label for something, and so they can't actually follow the written instructions in the package. And we have a long history of that in the scleral lens world. It's getting better as we get newer products.
You know, I remember when I first started fitting scleral lenses in the late 1990s. Okay, so there weren't any solutions for scleral lenses, and I remember a couple of us, us early adopters back in the 1990s, you know, sitting around saying, you know, what do we even fill these things with? You know, we didn't even know what to fill them with. So that's why we started using inhalation saline. It was just kind of like a group collective decision to start using inhalation saline because it was less bad than filling it with MPS solution or preserved saline. And so, you know, it was the least bad, I should say. So, you know, we have a long history of adapting to products out there. And we're fortunate now because we have so many products that are scleral lens specific now. And I think that, you know, it's been 30 years in the making.
It's been
25 years.
One after another rollout. So another area related to the solutions, the products and so on, that's a real issue for patients is product shortages, right? These are still a reality. I mean, thankfully, the preservative-free saline world is in much better shape now than it was 4, 5, 6 years ago. But yet, if I only know about the brand that my doctor told me about, and I can't get that because of a short-term shortage or my supplier's out or something, then I'm at risk of using something inappropriate because I go to the drugstore and ask the pharmacist potentially, right? That goes back to what you were saying about drilling that into the patient. You got questions, call me, including about the solutions, right?
Yeah, you know, it's important. It's important for people to call their practitioners for 2 reasons. One, for their own eye care, but believe it or not, often the patient finds out about the shortages before the doctor does. And I'll tell you, a lot of these backorder supply chain issues, I will find out from patients because I don't sell the product out of my practice. So I don't know until people call me up and start saying, I can't get this or I can't get that. And then, of course, my go-to is I call Rebecca. It's like, what are we going to do? How are we going to manage this? But yeah, it's really hard. And it goes back to communication, right? That the patients need to communicate with their doctors to find out what the alternatives are. The doctors need to communicate with the other doctors. So behind the scenes in our Facebook groups, in our, you know, through the Scleral Lens Education Society, we are also talking, you know, what are we going to use as an alternative for these products out there?
One more issue related to our supplies that I just want to flag up because I personally believe this is an issue that's going to be amplified more this year with more patient concerns about it, and that is product safety. We got over-the-counter eye drop safety issues and preservative-free ophthalmic product safety in general. This is coming up more. It's going to continue to come up. I'm just wanting to kind of flag it as a thing. Patients are going to be looking to providers for some reassurance about what they can safely buy and where they can safely buy it.
Yeah, this is, again, you know, when right, going back to talking about throwing too much information too quickly at people. And, you know, so we have to decide when are we going to layer things on, right? Because if you layer everything, it's like putting on perfume. If you put it all on too fast, you're stinky, right? You can't get past it. So you have to layer these things on in palatable, you know, layers. And the part of the problem with these, different products that are having issues and things like that is that it's all happening so fast that many of our practices can't keep up with it. So if we're a heavily, you know, written practice, here's the things I'm going to give to you to take home. It's very hard to derail that train, to move the things in the practice, because as doctors, we're thinking about all these other things. We're thinking about not only patient care but payroll and all these other things. It's hard to change our handouts, right? And so when it comes to things like these these issues with the non-preserved eye drops and the patients, a particular brands, and patients were being harmed and stuff. Really, honestly, Rebecca, this is where organizations like yours, Facebook even, are really vital tools to our practices. We really need to embrace social media and other connections. People like you who are very patient-centric often bring these problems to us before we, as the doctors, actually know about it. So again, going back to, I said, it takes a village to raise an eye. These types of communications are part of that village. And I think that it's fantastic when patients, hear about these things on social media. They call their doctor. The doctor is then able to find very reputable resources to get educated, whether it's through our national associations or through the Scleral Lens Education Society, through our academy, through the FDA. We are able to source out information that we can then bring back to our patients and know how to handle them in our practice. So it's very circular, what we keep needing to circle back on each other for support. As doctors, we need our patients as much as patients need us. Like, we need to lean on each other because we're a team, we're a partner together in this eye care. We're not whole without each other.
Absolutely. All right, I want to hit a couple more questions, and then we're going to look at kind of troubleshooting daily wear, a couple of key issues there. So Karen is a Stevens-Johnson syndrome patient since 21, who's got some questions about whether scarring and things will ever go away, or whether that's case by case. These are, I think, medical questions kind of out of the scope of what can be addressed here, but is also just saying, I wear sclerals and they are never comfortable. Anything you'd like to question that she could take her doctor, or any Pearl?
Stevens-Johnson is a different, is a unique entity. And I'm big paintbrushes here, right? Karen, I can't speak to you or anybody in case in particular. But Stevens-Johnson is a difficult entity because everybody is a little bit different. Everybody, but they all follow a similar pattern. As far as scarring, sometimes our goal is to prevent further scarring. We need to prevent keratinization of the surface of the eye so that the eye doesn't turn into skin. There's lots of things, lots of techniques that we can have with scleral lenses that we can create and optimize the surface of the eye to prevent pain, to prevent scarring. In some cases, I can see some scarring reverse, but keep in mind, Stevens-Johnson can be an ongoing process, so it can be a little bit difficult. So it's a difficult disease. It's a very, very difficult disease to do. As far as being comfortable, though, it really comes down to understanding the surface of the eye, the shape of the eye, and the ability to manipulate the shape of the lens and create a lens that's the same wonky shape that needs to be cut out around the symblepharon. So it's really about understanding what's going on there. The eyelids play a huge role with SJS syndrome. They're fibrotic, they're entropians. There's a lot to unpack here, Karen.
So I loved a complicated one at you. Now we've got two related to lens insertion. So Angie is asking, have you ever encountered a patient whose eyes were too deep set to use a scleral lens? I'm asking because a contact lens specialist discouraged me from trying a scleral lens. However, the cornea specialist said a scleral lens is my best option.
I never have. I see some pretty deep eyes. I like a good challenge though, right, Rebecca?
I like that answer. Thank you. That is a really hopeful answer to me.
Yeah.
Okay. And Valerie is asking, Valerie says, a Facebook member recently posted that you should not push the lens into your eye or it could cause the lens to be too tight. Have you heard of that? Now, I did hear through somebody else. I haven't been on the Facebook group myself super recently, but I heard that there was a discussion about this because someone was really kind of jamming a lens onto their eye. Can you speak to that a little in the insertion process, whether you can press too hard? In
Oh
our
gosh,
least
um, I I think it depends a little bit on the fit, the underlying disease, right? I mean, people can be pretty squishy. I personally, my personal fitting technique, and it's hard for me to speak to other people's because there's lots of different theories out there. My personal fitting technique is to fit, we jokingly call it large and loose, right? So I don't tend to fit lenses that fit on the tight side. I tend to fit a little bit bigger. I like a little larger landing zone because it's like a snowshoe versus a stiletto heel, right? A snowshoe. So my lenses don't tend to pull a suction underneath them. That's just my personal fitting. So I think that it tends to be, I wouldn't worry about somebody trying to jam it on them. I'd worry more about their fingernails and other things that they have going on with that situation. But I would have, it's hard for me to talk to that. But having said that, if you have like a suction cup, and you push it down, right, it can suction pretty hard, onto something. So I think that comes down to the disease, the fit, the size of the lens. How hard are we really talking?
Right, exactly. Okay, thank you. We've got one more on insertion, and an anonymous attendee is asking if you could please elaborate on the BandAid method.
On the eyelids. Yeah. Okay. So it crazy how well this works, but you take a BandAid and the brand actually matters, okay, because the stickiness matters. But you take the BandAid, I'm gonna get a little closer. You take the BandAid and you tape it to right below the eyelashes and right next to the eyelashes. So you got the BandAid like this. Leave the end on. So you have a sticky part here and here, but leave the other end of the BandAid on, and you grab those and you just pull them like this and you just open your eye up. Did I elaborate enough? Did that work? So you got BandAid here and a BandAid here, and you just pull that way.
You're kind of inspiring me to make a scary video.
Oh, yeah. We should make a Halloween video of all the scary things people do.
Okay, we are coming down to the wire on time here, so I want to get into kind of troubleshooting daily wear and the stuff. Okay, we've gone through the fitting process. We've learned how to get things in and out safely, comfortably. We're good, but we just have issues along the way. We have 100 questions, and again, since we don't necessarily know what we don't know, a lot of things will come at this stage for us. We'll come back to what the heck is normal. Is my experience normal? Is it normal for people to have to take out their lens and rinse it off 5 times a day and put it back in? Is it normal for my eye to look terrifying when I take my lens out at night? We just don't know unless we're told. A scenario that is like one of my most dreaded Facebook posts, right, is somebody posts a picture of an icky, unhappy, red, sore eyeball and says, this is how my eye looks after I remove my lens at night. Is this normal? And they get the usual barrage, and all due respect to everybody in the Facebook group, because I love them all very dearly, but we get this barrage of Facebook responses, which are, yes, that's normal. My eyes look like that every day. And no, fire your doctor, and everything in between, right? So how do you, I don't even quite know how to ask the question. You probably know the question I want to ask. How do providers make sure they're getting the information they need about our experiences once we've gone away to live our life with our sclerals?
Yeah. So again, it comes back to what is underneath that piece of plastic, right? So for example, if you have severe ocular surface disease like SJS or graft versus host disease or pemphigoid or one of these horrible diseases, sometimes those eyes can look so quiet and happy when that contact lens is on the eye and you take that lens off and those eyes look so unhappy and so red and so inflamed. So in many cases, we are using the scleral lens as a bandage to keep the ocular surface quiet. And when the lens isn't there, the ocular surface is quite upset with the situation. And that's different than keratoconus, right? I would not expect somebody with keratoconus to take their lens off and have a red eye. Keratoconus is a rather non-inflammatory disease. So, it comes back to communication. If somebody with keratoconus calls me up and says, my eye is really red, I'm thinking, what do you have going on, right? We've got a toxicity situation, we've got infection, we've got something else going on. Yeah.
How do patients know what to report as being unusual?
If in doubt, call me. I will tell you. There's absolutely no substitute for communication, right? Take a picture and send it to the practice, right? Just cell phones are fantastic, right?
And we've got all different kinds of practices. Who would typically be the point of contact? Is it going to be the optometrist? Is it going to be a technician? Who should their go-to be?
Well, it's probably always going to be a technician because the optometrist is probably quite busy in the practice, right? And many times it's something that the technician can actually answer. If you have a question, the chances are everybody else has that question, right? So if I get a question enough, I'm going to say, I should preemptively, I don't want everybody to call my practice. I'm going to start including this in my talk. It's how I got better over time, right? It's how I personally went from a newbie to experienced, right? Is handling these things. So there's no substitute for communication and support, direct support. I would rather have somebody call me and say, congratulations, you don't have a problem, than have them not call me and say, if I'd gotten to that ulcer 3 days earlier, we wouldn't have an issue.
I love that. Communication is tops, and having somebody that we can call and share what we're concerned about. Absolutely. Knowing that that's a safe thing to do, because, sometimes patients would rather talk to anybody else than try to call the eye doctor's office and get through about something, because we're afraid it's too trivial. We're afraid it's a dumb question. We have 1,000 reasons not to call the eye doctor, right? But if a provider is going out of their way to tell us that they want that makes all the difference in the world to whether we're going to reach out for that level of support. We've got another anonymous question. Should great fitted lenses result in 100% symptom-free or more like symptom improvement? I still feel dryness with lenses, but that's coming from unusable eyes without lenses. Should I adjust my expectations? And I know this again is out there in medical land. I would just like to say, as a fellow patient, I have not ever expected 100% symptom reduction with my lenses in my circumstances. It's like I find where my new acceptable place is. It's all, for me, all about the incremental improvements. I wonder for this participant, could you suggest how do they phrase a question to their provider about that?
Yeah, remember, you have two sides to that contact lens. You have the contact lens to eyeball side, and then you have the contact lens to eyelid side. And if you have really dry eye, the contact lens to eyeball side is getting liquid held to it. It's being covered up. So the eyeball is being protected. But that eyelid is still dragging itself over a surface that is constantly exposed to the air. So while you may have a huge amount of relief because the eyeball itself is being covered and no longer in pain, you're still going to have symptomatic dryness because of the eyelid to front of the surface of the contact lens. And that is where some of the coatings, solutions, things like that, we can help, sort of like putting WD-40 on your door, sliding glass door, right? You can try to, but that's going to wear off over time. And so we always have to have our expectations of where are your symptoms coming from? And can we expect the contact lens to manage those symptoms? Or are we just going to give you a new set of symptoms because we also have a dry surface that's never going to be not dry? And again, this is a conversation that should happen way early in the fitting process. This is a conversation that should happen before that lens ever goes on the eye.
Awesome. Thank you very much. So we're heading to the end of our time. We are just past 6:30 here. I would like to just very briefly rattle off a last few thoughts just about things I think patients appreciate a lot from their providers going through this process. One, that very thoughtful, insightful orientation process and discussions like Dr. Sindt's been describing, to access to all different kinds of tools and techniques for lens insertion and removal. That's like the insertion process is one of the things where patients get most hung up kind of in our community. 3, everything written that they can possibly get as memory aids. And 4, as Dr. Sindt has been emphasizing, somebody to call. The reassurance that it is not only okay to call, but necessary to call when you've got concerns.
For both parties. There's 2 people in this relationship, right? It's a doctor-patient relationship, patient-doctor relationship. Like, everybody needs to communicate because both parties are human. And we have to remember that.
It's so helpful for patients to hear about what this is like from the provider side too. Yeah, so we do understand we're in this together. Any last words of wisdom about our partnerships with our doctors?
There's 2 questions over here. So one is, will manufacturers make lenses in color? And the answer is probably unlikely. They're probably going to come maybe light blue or clear, but I don't think that you can expect anything more than that from the button manufacturers. Lots of reasons for that. Probably requires sitting down with a cocktail at some meeting. And then the other one is, how would you recommend working with a patient with severe disease that requires extra time, 2 to 3 times more than a regular fitting, and is combative? Wow. Wanting what they want in one setting. Well, that comes back to expectations, right? I think that what I find is that when people are combative, they're just hurt. They're just sad. Something isn't working well for them, and they're frustrated and they're angry. And that's just a manifestation of that anxiety that we were talking about before. And finding out, kind of digging into them a little bit and finding out where that is coming from is the only place to handle that. And then in my experience, we move forward in such a caring and respectful way for each other that often these are some of my just love them patients, but they come from such a hurt place.
I wonder if I could suggest just a little question to toss in there for the patient, which would be, do you have the support that you need for this process? Just as a way to acknowledge this is hard. I mean, I think when you've got both ocular surface pain and vision stuff, man, everything is amplified. These are the sort of people that we, through the dry eye helpline at the foundation that we talk to all the time and love to, just as a way to get them some support outside of the setting as well.
And the other is phone a friend. As a doctor, I call colleagues all the time, daily, I am texting my colleagues. Daily, I am asking questions, right? Rebecca, I probably text you multiple times, a week asking questions. Like, call a friend when you are seeing some of these things, because maybe this is a person who's been through so much, you need to send them to somebody who's like, I'm an expert in this offbeat disease or something, So, all right.
This has just been such an amazing time. Thank you so very much.
No, thank you. Thank you. And thank you, Dr. Tucker.
Thank you, ladies. That was so fantastic. I so appreciate your insight and your just ability to connect with both doctors and patients, Dr. Sindt. That was just so informative, and I really appreciate all the information.